Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. I'm your host, Dr. Andy Cutler, and with me today is certainly a very, very good friend and an expert in the field in many areas, but certainly what we're talking about today, I would say, is right up his alley. So with me, of course, is Roger McIntyre. Roger, how are you?
Hi, Andy. Always fun. Good to do this together again.
Yeah, looking forward to it. So we're going to be talking about long COVID syndrome. And, Roger, since we kind of left COVID in the rearview mirror a couple of years ago, people may not be talking as much about this or focusing on it, but there's still many people out there suffering with long COVID. So maybe you could just tell us, what do we mean when we say long COVID?
Well, Andy, it's interesting. I think we're all very happy to see COVID in the rearview mirror, but that old phrase, something to the effect that you can leave the history, but the history won't leave you. I mean, these things stick around, and so we go back to 2020, the annus horribilis, the horrible year that it was, and yes, we all know the pandemic, of course, and then overnight, it seemed, we had this new entity that was described, wherein people who had been infected with COVID presented with a whole host of nonspecific symptoms that were debilitating, that were persistent. And these symptoms were quite common in people. And there is a legacy to this, or in the sense that people, or history to this, that we know that there are a rich history in medicine of infectious conditions resulting in a chronic sequelae, and this seemed to be history repeating itself all over again. And that phenomenon was sort of really caught on Facebook type and internet type chat groups and so on, referred to as long COVID. The NIH came out and the CDC came out with a different moniker, the post-acute sequelae of COVID, or PASC. And the WHO also had their own monikers, so-called PCC, post-COVID condition. So different names, but really describing this phenomenon, Andy, of really a long list. In fact, last time I count, more than 50 different symptoms or signs. And I can't think of a single organ system that wasn't affected with respect to the origins of these symptoms and signs that affected a non-insignificant group of people within, say, 2 to 3 months of the infection and persisted for a couple of months. That I'm just going to call post-COVID condition, the WHO moniker.
Sure. Yeah, Roger, you and I share a long-time interest in the interaction of the brain and the body, and an area that I fell in love with in my residency called psychoneuroimmunology. Boy, very few conditions illustrate that better than this one. And so we'll be focusing on the neuropsychiatric effects. Of course, as you said, it can affect any body system. But clearly this speaks to immunologic dysregulation. And maybe you can share a little bit about your background and what drew your attention to this in particular.
Yeah, it's interesting, Andy. Like yourself, I've been very interested in the immune system. It was just a topic that, like a lot of things in our life, you go through university and college and so on, and it was something I always had an interest in, but really took an interest in medical training. And then when I went into psychiatry, it really, in fact, has been a focus of my research for much of the last 2 to 3 decades. And as you know, more narrowly, Andy, focusing on the domain of cognition, the domain of reward. I think, if I was asked to put it very succinctly, I would say that in many cases, alterations in reward function, we call it anhedonia, or amotivation, or alterations in cognition, in some cases could be explained in part by some alteration in the immune inflammatory system. And many people hear about this at NEI each year. We speak to this topic. Purposely, it's a very hot topic, continues. In fact, the GLP-1s have taken off as a potential treatment in psychiatry, in part because of their anti-inflammatory immune modulating effect. So this is not just academic pet project. This has really got into the public square, so to speak, with respect to the common interest in the field. The other part about this, Andy, for me, which is interesting, is the fact that why I thought about this is that when I heard, like everybody else did for the very first time, and in late 2020, this new condition called post-COVID or long COVID. And it was this phenomenon linked to a virus, somehow linked to immune dysregulation. People were very fatigued, very tired, profound fatigue, and also profound cognitive problems, so-called brain fog.
Okay.
As someone who studied immunology and cognition and reward, I thought, wow, this is interesting. So sometimes, translationally, you can learn a lot about your area of primary focus by looking at a related condition that may share pathophysiologic aspects. And that's what got me interested. Frankly, and just parenthetically, Andy, I've always been interested in history, as you know. I like to throw history tidbits out when it comes to psychiatry and medication. And look, I'd heard of the Spanish flu before COVID. I can't say I heard about it as much as we did in 2020. We all became experts on the Spanish flu. I wasn't that much of an expert on it, nor did I have that much interest in the Spanish flu. But I did recall, vividly reading that in the 1920s, it was very common actually for psychiatry and neurology, and frankly, many other specialties, to encounter patients who were infected with that flu, which was also a similar type of virus, actually, where people were presenting with these terrible fatigue syndromes. And they called it encephalitis lethargica. And it was a very common problem. It may have been the post-COVID of that time, so to speak. Encephalitis lethargica. To keep going, but not to be over-inclusive, people, in fact, also had new onset sort of Parkinsonian type presentations, new onset movement disorders, and it really befuddled psychiatry, it befuddled neurology, it befuddled, just medicine in general, but clearly triggered by exposure to the so-called Spanish flu. So this is sort of history repeating itself. And as I think many of our colleagues joining us today know, there's really a plethora of examples where an infection, in fact, could trigger some neuropsychiatric condition. We often talk about, PANDAS, this pediatric autoimmune neuropsychiatric associated with strep, and so on and so forth. So this is not a new concept, but we had this enormity of people who were complaining of this problem that I think overnight made it a public health concern.
Sure. I certainly remember during my residency, as I'm sure you do, admitting people to the hospital and checking their RPR, looking for neurosyphilis, which is perhaps another example.
Absolutely.
You've mentioned some of the neuropsychiatric effects, fatigue, cognitive impairment. What are some of the other neuropsychiatric effects? And I realize it's protein and it can be almost anything.
Absolutely. People can experience just about anything. Those are certainly the most common, so-called brain fog, and which of course is not really exact what that actually means. But I think it's one of those kind of things we sort of know what it means, but it's not really lent itself to an easy translation. But certainly cognitive deficits described with a variety of lexicon and vocabulary are certainly very common. All aspects of reward, in other words, motivation. The fatigue is not just your sort of everyday fatigue. This is fatigue described as even beyond psychomotor retardation, even beyond leaden paralysis. This is people who literally walk 2 or 3 steps and are just exhausted type fatigue. So a different type of fatigue. Also, along with that, people would have problems with having problems with their mood. Frankly, people were depressed. There was a lot of anxiety, which then begged the question, is long COVID or post-COVID, is that really a new entity? Or is it just really a form frust, a variant of depression? I don't think it is, but that question was legitimately brought up at the time. And then along with that, a lot of non-specific types of symptoms and signs, Andy, like people would, sort of in the neurologic area, maybe some visual problems, smelling problems, taste problems, gustatory type problems. And that's just above the neck. Below the neck, you pick the organ system, and then you can pick the symptom or sign. People had it. Like I said, I looked at this about maybe 3 or 4 weeks ago. Last time I keep on top of this literature, it still interests me that, over 40, 50 types of symptoms have been described, and there's no organ system that seems to be spared. But the most common and the most debilitating in most studies are in fact related to what we talked about, no surprise, that being the fatigue and the terrible cognition. And this has sparked up a lot of interest, not just from us in academia, but the CDC and the NIH has also taken a lot of interest in this.
Yeah. Well, you and I have certainly talked a lot and published and lectured a lot about anhedonia and cognition, and those are the two two of the most pernicious symptoms of depression and linked very highly to functional impairment. So I can imagine how functionally impairing this is. Roger, you said it's not uncommon. Do we have a sense of how common it actually is? And then, of course, are there known risk factors? I mean, we're probably talking about risk factors that we don't even know yet.
Yeah, there's quite a few risk factors that we don't know, but we certainly now, 5 years out, hard to imagine that we do have a fairly handsome list of risk factors. A bit like suicide, we have many risk factors, but there's a few that really come to the very top. So maybe I'll just focus on those. First of all, is that the prevalence of this condition has been variably estimated, of course, based on how you define it, but also depends on where post-infection you're actually looking at it. In other words, if you and I were to do a survey of people who were infected with COVID a month after the infection, or 3 months, 6 months, 12 months, 18 months, we get slightly different estimates. And yes, it's true that the estimate at 12 months is lower than it would be at, say, 3 months. Taken together, according to the CDC, between 3 to 6% of Americans, between 3 to 6% have long COVID or post-COVID, whatever you want to call it. So not infrequent. But again, those estimates vary depending on where we look. Secondly, there are risk factors. First, one of the risk factors that's been replicated, women are more at risk than are men. Second is another risk factor, Andy, relates to the actual infection itself, that being the severity of the infection. That is the person who ends up in hospital, for example, because of the infection. We don't hear about this as much as we used to, but back in the day we did. Thirdly, vaccination status. People who are vaccinated against COVID who got COVID are much less likely to eventuate with long COVID. In other words, the vaccine protects you against long COVID. And the other part about this is a prior history of either depression and or diabetes. There's many other conditions. I'm trying to keep it brief, but that's of interest to me, Andy. I'm kind of selfishly interested in those two topics, and that makes a lot of sense to me. So because we know that depression, among other things, is a condition that in many cases affects the functioning of the innate and the adaptive immune system, but so is diabetes. And so women, people who have had a severe infection, vaccination status, current past history of a chronic metabolic inflammatory condition called depression or diabetes mellitus are very replicated risk factors. These are not, identified by one study that no one's ever heard of. These are highly replicated risk factors. So you can kind of see how there's a bit of parsimony here, like how this sort of gives reason to believe that maybe some of the mechanisms involved in the cognition complaints of the long COVID or the fatigue of long COVID overlap to some extent with similar complaints that we hear about in depression and other mental illnesses.
Yeah, fascinating. The one that may not be as well known to our audience is the vaccination status. And as we're recording today, Roger, this reminds me only a couple of days ago, there was a shooting at the CDC in Atlanta by a gentleman who had blamed the COVID vaccine on his depression and some of his problems. And
I see.
So yes, clearly there's risks with any vaccination, but this really is a benefit that outweighs, in my opinion, the risk, if you talk about that.
Oh, absolutely. And as we know, the COVID was unpleasant in every regard, but certainly it was a time, as we know, it was a political aspect to it as well, which was quite unfortunate. But that aside for a moment, I've learned, Andy, in my career that no politics. We'll leave that aside. But I think it clearly was politicized. It's unfortunate because the big picture of public health was lost. And there's no question that, yes, the vaccine, when people did receive vaccine and did become infected, there was less post-COVID conditions. Some might say, is that because the infection was less severe? Maybe. That's true too. Maybe it's just a function of that. I don't know. Or was there something about getting the vaccine that maybe muscularized, if you will, your immune system? Our immune system, as you know, Andy, has got good guys and bad guys. It's got sort of a bit of both in there, and maybe it sort of muscularized the good guys so that when to protect us. I mean, that's just, of course, that's a kind of a heuristic. I don't know if that's true, but it's absolutely the case that vaccination status does reduce the incidence, the severity, and the persistence of post-COVID condition.
Hopeful. Well, let's get into a little bit of the pathophysiology. How does neuroinflammation factor into this? And I have to tell you, I have seen a couple of recent articles talking about a variety of theories, and one of them is the sequestration theory of the virus.
Yes.
There's others that elements of the virus can actually be incorporated into the nucleus and so on. But what would you say is sort of the pathophysiology here?
That's right. That's right. And right now, with respect to the pathophysiology of post-COVID condition or long COVID, I think we start off with the first comment is it's heterogeneous. Second is because the phenomenologic presentation is so heterogeneous, the underlying neurobiologic substrates are also very heterogeneous. So we would hope we could have a kind of a one-size-fits-all reductive explanation, not quite so easy. I mean, to that point you mentioned, that's an interesting possibility. There's some data to support this possibility that there continues to be this sort of sequestration or this reservoir of viral remnants and or the protein related to the virus that is still, for example, in the neuron or in the glia or other tissues. And because it's there, of course, it's a foreigner, it's triggering the reaction of the immune system. That's certainly been and there's data to support some of that in some studies. Again, these are not mutually exclusive. Another theory that has been put out there is just simply one where, okay, you had this virus. This virus is like a Category 5 hurricane to what it does to your immune system. So it's just a 5-alarm fire. It just does everything to your immune system. And so you get the friendly fire that's just been activated, and this is what's causing it. A third theory, which is interesting, is one around maybe something around the vascular. I remember back in the days we all remember when COVID happened, watching the news programs in the evening, you'd see people going into the ER and they're all decompensating. Everyone's aware of the fact that the pulmonary system and the vascular system is greatly affected by this virus. It becomes very permeable and impaired. And some people would put that forward as a potential hypothesis as well. It's more of a vascular explanation. I'm not being exhaustive. Those are really the three leading. There's a few others, but those are probably the three leading. And that's important because, Andy, as you know, we try to match the treatment to the mechanism. And we're going to get into this in a moment. I don't think we really have yet a clear line of sight on the pathophysiology. Because of that, we don't have a clear line of sight on what the right treatment is for this. And I think that's something I guess we'll talk about soon. But I think those are the three major ones. One other point I might mention is that I mentioned this in passing, is a lot of folks with post-COVID condition, they often have other problems like obesity, type 2 diabetes, they have depression, other conditions going on. And so that's made it very difficult to suss out a explanatory mechanistic framework because it happens, of course, but more commonly you have this Venn diagram where post-COVID condition is occurring admixed with other problems that were going on in the first place. So it makes it very hard if you're a detective trying to get in there, trying to figure out what's the crime here, to really suss this out. That's made it very, very complicated.
Right, and that's the question I wanted to ask too, is how about this, how do you distinguish the new onset psychiatric stuff from maybe pre-existing, and are there differences in the kinds of psychiatric presentations you see with long COVID versus our, standard traditional, if you will, mood and anxiety syndromes?
Yeah, that's a great question, Andy. And we did a little bit of work on this, looking at that insofar as we did look at the type of presentations. One of our team members at the time, and I think, look, we know depression is heterogeneous and just like long COVID, but it is maybe not surprising that people who had those depressive symptoms with post-COVID tend to have more of that sort of psychomotor retardation, that profound aspect of fatigue, profound anhedonia presentations. We did studies, interventional studies, looking at people who are living with long COVID. And as someone who's worked in depression my entire career, these were really phenotypically overlapping. I mean, people who don't meet the criteria for a depressive episode, but it really overlapped. I don't think they're the same thing. I really don't. But there was a tremendous amount of overlap, maybe not surprising, more of this commonality around the fatigue and that retardation.
Yeah, that certainly makes sense. So we can certainly look for that. And then obviously taking a careful history is critical to see what was there beforehand. But it's interesting that you said that pre-existing psychiatric condition can also be a risk factor here.
Yeah, absolutely. Absolutely. And on that note, Andy, we if we were to sort of just be speaking about major depressive disorder, which is not our focus, but let's say we use that as just a disorder that obviously is a brain-based disorder, an area that we have implicated as altered in structure and function, among other areas, is the striatum. And you have ventral and dorsal striatum, and the ventral striatum, we think more around the reward valence, and of course the dorsal striatum, more motivation and activity. I often refer to, Andy, the striatum as the Hemsworth part of the brain, in the sense that when you think about the brain, it's not just about reward. We also want to have reward and motivation linked together. What's interesting is that both of these parts of the brain, the ventral striatum, the dorsal striatum, are also implicated as being altered in post-COVID condition. I think it's interesting because it does overlap with what we talk about in major depressive disorder. But I don't want to suggest these are just form variants of each other. They're not, but we do see that sort of brain correlate of the fatigue and psychomotor retardation that we do see.
Cognition is always difficult for clinicians to assess and monitor, but if we're talking about the brain fog here of the post-COVID condition, how should clinicians think about assessing it, monitoring it, and so on?
We did a study in long COVID, and what we did find is that that there is, in fact, a treatable element to this. In other words, we did a study where we took people with long COVID, and we had treated them, in that case, with vortioxetine. We did a study with vortioxetine. Now, again, we were using vortioxetine in the study, not so much because it's an antidepressant, and we really just think this is a variation of depression. That's not why we did that. Everyone knows vortioxetine is an antidepressant. What's probably less well known is that in addition to its effects on the monoaminergic pathways and glutamatergic pathways, it's also very much active on some of the inflammatory molecular and pathway systems. For example, vortioxetine increases the expression of the gene for the PPAR gamma protein, which is involved in immune modulation. It's also takes microglia, because microglia are your friends and your enemy. And when they're in what's called an M1 phenotype, that's pro-inflammatory, that's your enemy. M2 is anti-inflammatory, it's your friend. Vortioxetine converts the microglia from M1 to M2, just like lithium, just like ketamine does. Yeah, and vortioxetine also has COX-1, COX-2 inhibition effects, even greater than indomethacin and other NSAIDs. So for these reasons, on top of the fact that it improves cognition reward, we studied it. But what we found was, just on that note of depression, is that we found that people who were living with long COVID, who had prominent depressive symptoms, when we could improve the depressive symptoms, which we did with vortioxetine, well, guess what? It significantly improved some of the quality of life and function related to the COVID. So post-COVID. So you do get it. So I think when you see a patient who has long COVID, it's important to take out your PHQ-9 or your device, screen for depression. There is, and see what's treatable there. And then there could be some dividend. Going back to what I said earlier, I said that I always refer to the striatum as the Hemingway part of the brain, because Hemingway said, don't confuse motion with action. And right. And so I've always seen like the ventral striatum is the action. I see the dorsal striatum as the motion. So the caudate putamen gets you off your seat, but it's really the ventral striatum, the nucleus accumbens, that gives you kind of valence and purpose to what your reward behavior is. And so I think that vortioxetine may be helping striatal reactivity, so to speak, insofar as giving an improvement in the reward function, but making them more motivated, which is also what we found.
Yeah. But vortioxetine is also somewhat unique amongst the standard antidepressants because it is effective for cognition and anhedonia. And
Yeah.
as we know, our standard antidepressants don't work as well for that. But I'm fascinated by some of these other effects you're talking about. Before we get into some other treatments, which I definitely want to talk about, you mentioned that these symptoms can affect people's ability to work, maintain relationships, and recover, of course, psychologically. But what I'm wondering first is this self-limited? Is it that if you wait it out, it goes away, or are there some people where it can just continue on and on?
That's a great question. That's why if you're an epidemiologist or work in public health and you're charged with the responsibility of giving us an updated, accurate, say, regional or cross-national estimate, how common is this condition? And it really depends on where you're assessing people in their journey post-COVID infection. The rates are certainly higher, Andy, after a year, 2 years than they were, say, 3 months after the infection. There's no question. Does that mean that this is a transitory or transient or time-limited phenomenon for everybody? No. It's 5 years out now, so it's not like this happened a day ago. This is 5 years ago now. And there is a percentage of people who continue to have this. Again, just shy, about 6%, it's between 3 and 6% is the estimate. Again, that's sort of a general estimate of the population in the U.S. have post-COVID condition or long COVID. My sense is it might be a little lower than that. That's my sense, because there is, in fact, now some data to show that the rate, say, 2 to 3 years out, is less. It's not like 1% less. It's maybe even as much as 50% less. But that being said, that there is a percentage of the population who have it. It's not insignificant. It's not a rare disease, if you will. So it's quite common to this point. And of course, that itself, that is the durability of the disturbance, provides some insights as to risk factors and also the pathophysiology, but also makes it a bit more challenging again because the therapeutics should be guided by the mechanisms. And whether it's the phenomenologic presentation and or the durability of the disturbance, we're seeing tremendous between individual heterogeneity. The other part is that we've seen this as well in our research, is not only is there heterogeneity between people, but within a person with post-COVID, the symptoms that were most impairing, say, 2 years ago, may not be the ones that are most impairing now. So you get that inter-individual, but intra-individual variations. It's just, anyways, as they say, it's complicated. But there is still a significant percentage of people who have this persistence of this problem.
Well, I can imagine that's frustrating and demoralizing. I mean, if it was something that was self-limited, maybe you could cope with it better. But I can only imagine the devastating effects this can have on people in every domain of their life.
Oh, absolutely. And I think the other part too, Andy, is that, and this has been reported and discussed on some of the support groups online and so on, of people who live with the condition. Look, you and I are psychiatrists. We know that psychiatry has never enjoyed a surplus of trust or a surplus of goodwill. I mean, there's a lot of mistrust around psychiatric diagnosis and treatment. This manifests, among other things, as stigma. And in keeping with the theme of stigma, I think this condition has also been stigmatized. There's been a lot of disbelief in this. I think there's been a lot of skepticism. I think part of this is the frustration. No one really knows what it really is. What are the boundaries of this condition? And so I think that, look, we as human beings, as healthcare providers, we get frustrated when we don't know what we're treating and it's not getting better. And I think that's played a part in this as well. But this condition has been stigmatized, and there's been a lot of people who have been very treated skeptically by the healthcare establishment. And when you go back, I mean, you look back at some of these so-called syndromes, and I'm not suggesting these are the same thing, but there's a theme in common, whether it be some of these sort of chronic fatigue syndromes, irritable bowel syndromes, sick building syndromes, where people get sick in a building, environmental type syndromes, and also, in fact, some of the infectious syndromes like Lyme's disease and so on. There has been skepticism. And I think that's added to the frustration that lived experience has had. I think that fortunately, I think now there's been, the NIH has put aside significant funding now, which I hope still exists, for the study of this condition. And so the government has recognized, yes, it's common, but also recognize, yes, it's common, but it's common in the sense that it's debilitating people, affecting their workplace attendance, performance. In other words, there's actuarial, there's economic cost to this, and there's good reason for us to be studying it. So,
No, it's interesting. Just as you were saying, chronic fatigue syndrome, it's exactly what was coming to my mind, and fibromyalgia are two others that we deal with.
Absolutely.
Some kind of stigma, not well understood, probably have significant immune underpinnings as well.
Absolutely.
Dysregulation.
Absolutely. Absolutely.
Well, let's talk about treatment. So you mentioned your work with vortioxetine, which I'm familiar with, and certainly great. I'll tell you something else that I had read about a while ago. When people started coming out with that sequestration theory, which is about 2 or 3 years ago, they started talking about using Paxlovid, repeat multiple courses. Perhaps you have to really, dig into the tissues and reach this thing where it is. What are your thoughts on that?
No, I think that, first of all, just to step back a step, I think that all options are on the table right now. I think we begin with, we don't have yet a fit-for-purpose FDA therapeutic. We don't have a treatment that's the gold standard, or that is the one that's proven with, replicated, adequate, well-controlled studies. So we have nothing that's considered the treatment. So therefore, we have a set of considerations. I think this one that you mentioned is very, very interesting. And there is, as you know, Andy, one of the areas of therapeutics that people are looking at are immune modulators, looking at monoclonal antibodies, looking at drugs that are not historically thought about as being immune modulators, but they are treatments like metformin or treatments like naltrexone, are known for that. So I think anything that's going to affect the immune system could be a potential candidate, right? And you and I have a bit of a fetish on the 5-HT2B receptor. It's a target of viloxazine, a target of cariprazine, brexpiprazole. There's a few others, and in 5-HT2B receptors, they're coding microglia. So if said, hey, I want to study viloxazine, I want to study cariprazine because of the 5-HT2B, I'd say that's a viable hypothesis.
Well, let me take you back. Let me take you back a few years, Roger. You might be surprised to learn that an old friend of yours, norquetiapine, the active metabolite of quetiapine, has significant affinity for 5-HT2B.
That's true.
Which is fascinating. The other receptor you and I have probably an unholy love of is the sigma-1 receptor, and we're probably all familiar with the fluvoxamine study that showed decreased hospitalization and death. And then there's, of course, the dextromethorphan bupropion combination on the market. So I'm wondering if that makes sense too, as far as having anti-inflammatory mechanisms.
Oh, absolutely. That's a good point. I think that if we did the randomized control, we designed it back in 2020, 2021, the vortioxetine RCT and long COVID, which, by the way, just to finish that thought, we were able to show that in people who had elevated CRP and long COVID, it would improve their brain fog, their cognition. If I was going to do it all over again today, what you just highlighted is pretty interesting. I think that looking at dextromethorphan, bupropion combination of long COVID would be absolutely something I would consider.
Yeah, it's very reasonable. NMD antagonism for anhedonian cognition. You have two very rational mechanisms.
I would absolutely consider it because in some ways, Andy, you kind of get three mechanisms, because you get the NMDA, which has its own anti-inflammatory pathway. As you said, the sigma-1 system gives you another anti-inflammatory pathway. And what's interesting is that when you administer NMDA antagonists like dextromethorphan, you're increasing GLP-1 release in the bowel, maybe also the brain. And we know that GLP-1 is an endogenous anti-inflammatory. So I think it would be a really interesting one to study for sure. That'd be kind of interesting mechanistically way to think about it. There's a lot of symptom-based therapeutics people are looking at, like stimulants, modafinil, solriamfetol type treatments. And that's intuitive. These people are fatigued, tired, and so it makes sense. And sure, I think that those make good sense. And to keep going, there's some colleagues who are, a lot of people are interested in some of the physiotherapy approaches, hyperbaric oxygen approaches. And I think let's not forget also what exercise type approaches, and also hearing more about some people were telling me they're looking at even TMS or neuromodulation, which I think is not unreasonable as well.
Sure.
And we're not fully exhausting the list, but this is
No.
capturing some of the categories.
Well, I'd be remiss if I didn't hone in on something you said there. GLP-1s, the GLP-1 agonists. What about them specifically and directly for this as well? And
I think so. I mean, yeah. I think so. I think that if one was to find a thread, I mean, let's face it, these are truly transformative therapeutics, and they're transforming the treatment of many, many conditions. And so we start off by saying that it has more than one mechanism of action. We don't think that this one mechanism explains all this. But if you were tasked with the responsibility to say, hey, look, can you come out with a parsimonious, reductive, thread across all of this, you'd be on pretty firm ground by saying it's the effect on the immune inflammatory system. And they are potent at that. And that would explain some of the weight, the glucose lowering, the apnea, the kidneys, the hearts, the brain, and so on and so forth. So I think it would be very interesting for people to look at that. And, off-label, just interesting, this is just a parenthetical because folks joining us, Andy, are very often clinicians, see a lot of patients. Just to be clear, obviously GLP-1s are not indicated for any psychiatric disorder or psychiatric presentation this time, not yet. But certainly goes way back quite a long time now, well over a decade. We were looking at these in my lab that we started to use these drugs off-label in people who may not necessarily be overweight or diabetic, but we were using them as off-label treatments for anhedonia and cognition. We were doing the research on it, so we were we believe what we're doing, and we're kind of seeing what we believe, I guess, and vice versa. And so that's what really got me very interested in those drugs and in developing them in psychiatry, among other things. So that I think for long COVID, that would be a viable thing to consider as well. Absolutely.
Sounds very reasonable. And of course, as you said, these are not mutually exclusive. These things could be used in combination, all of the above. Yeah. As with other psychiatric and medical conditions, there are certain populations that are underdiagnosed, undertreated. And we're talking, of course, about minority populations, disadvantaged populations. Is the same thing being true here with COVID and long COVID?
It really is, and this has been reported, and there's no question that that's the case. There are in fact more reports in, as you mentioned, some groups, and we have minoritized group on the basis of race or ethnicity. We have minoritized group on the basis of gender. We have minoritized groups on the basis of economic background. I've got a few others I can even list. But I would say this, that yes, there has in fact been, for example, more of this reported in some economic disadvantage and also in some racial groups. Now, people have raised the question, is this aspect a risk factor, or is this aspect a pseudo-specific risk factor in the sense that, for example, some people of certain groups are more susceptible to obesity, and obesity is a risk factor for long COVID. And we get into these kind of interesting academic, mediational, moderational questions, right, and so on and so forth. But it's absolutely the case that we do see that. So there are socio-demographic aspects that do influence. I mentioned female, but also some racial groups may be more susceptible to it, whether that's a mediational effect, in other words, it's a direct risk, or it's because of the association with other risk factors. That's to be determined.
Right. Well, I remember, Roger, a couple articles coming out earlier on in the pandemic about people with psychiatric conditions being disproportionately infected with COVID, such as schizophrenia, bipolar, even people with ADHD who may be more impulsive and so on.
That's right.
I'm imagining we might be seeing this in our psychiatric population as well, because just the volume, if there are more of them affected with COVID, you're going to have more long COVID.
Yeah, that's right. That's right. And that's why I do think, look, we're all busy and we don't have, no one has a surplus of time. And so when you see a patient who is presenting with some of the symptoms we are describing, especially when someone has, at least in their own opinion, the the focus of clinical concern is long COVID or post-COVID. And for them, that's the explanatory diagnosis. Well, that could be the case, but I would just encourage, and this is not to offend the patient, just to probe if they do have ongoing depression or other conditions present, because other conditions are treatable. That's not to say long COVID isn't, but we do have proven treatments for depression and other conditions. And we did show that when you improve those symptoms, the impact on the burden of COVID, post-COVID, is reduced. So at the end of the day, I become very agnostic. I don't care how we can reduce the morbidity. I just want to reduce the morbidity. So I would encourage that people should be yeah, and we saw that with a pretty robust effect, actually.
I'm thinking about anti-inflammatory and immunomodulating therapies. Are there certain aspects of the immune system that are more affected than others? I mean, you talked about the glia. There's T cells involved. Are there certain clues as to, because there's different targets within the immune system, of course?
Yeah, that's so true. And I think that all parts are affected in long COVID and all parts are affected in depression. So, just for everyone's reminder, we also did this back in college, that, you had the adaptive and you had the innate immune system. And we remember the sort of cellular systems like the monocytes, the macrophages, of course, they're sisters in the brain known as the microglia. And then you had the sort of the humoral system, which was the various antibodies and so on. But all of these are affected in people. I think that we've expanded it, Andy. I think that the immune system is not so narrowly just cellular, humoral, adaptive, innate. It also includes other aspects like the acute phase reactants produced in the liver. You've got some of the cellular mediators that are responsible for the integration of the epithelium, like in the vascular area. These are cell adhesion molecules. They're so-called chemoattractant proteins. People might remember complement is another type of protein. And then to add sort of some further complexity to it, that the immune system is so inextricably intertwined with the metabolic system. I mean, insulin it has effects of that are anti-inflammatory, and so once you start having a lack of insulin sensitivity, you start seeing a provocation of the immune system, and so you have this as well. So it's very complicated. But one thing is very clear is that once the immune system is activated, I was going to say it's like a snowball coming down the hill, but that's a very Canadian example. Once it's activated, you've got to get into this vicious cycle and stop it, because it becomes a vicious cycle very quickly, and you want to turn it into a virtuous cycle. Just recently, Andy, you may have seen the extraordinary media attention that was given to an article just published recently on lithium in Alzheimer's disease. We've known this for a while, but this was for those maybe who missed the article recently, a set of elegant studies done in animals, but also in human brain, showing that in human brain, we have lithium endogenously in our brain. It's a normal element in the brain. It's a metal. Now the level in the brain is 1,000 times less than we would see in someone who has bipolar disorder that we're treating with lithium. But nonetheless, it's normal to have lithium in your brain, and what they reported, which was really interesting, is that people who have Alzheimer's disease or people with MCI, mild cognitive impairment, in the postmortem brain, the lithium levels were considerably lower. These are not people with bipolar. This is just people was considerably lower than people who had normal cognitive functions. And what was interesting, and just to sort of finish my thought there, is that, see, what lithium does, lithium's like a sponge. And when you have amyloid and tau protein, lithium binds to it, which allows for it to be eliminated. That seems like good news. But the bad news is because lithium is being used up, so to speak, to mop up the amyloid and the tau, lithium's not around long enough to make sure the microglia is behaving itself. And microglia, see, the lithium's like the homeroom school teacher. Once the lithium leaves, the students all start acting up. And so the microglia starts acting up and starts becoming very pro-inflammatory, which then gets the vicious cycle, which is more amyloid, more tau, right? So it's very interesting. So we really want to try to, the immune system has this incredible viciousness about it unless you actually stop it in its tracks. And which, by the way, raises the interesting question. It may seem counterintuitive to some, but I don't think it's that counterintuitive, actually. Maybe lithium could be a consideration in long COVID.
100% agree with you. And by the way, that article, I actually have it in front of me right now. It's on my computer. And it was published in Nature almost exactly a week ago, August 6th. First author is Aaron, A-R-O-N. Review Aaron. And of course, you know who I had a very nice, robust discussion with about this article is our friend Jonathan Meyer.
Sure.
Who has written the Lithium Handbook. And it's also fascinating, Roger, that the form of lithium that they found to be more effective was the lithium orotate, not not the carbonate that we usually give. And that's available over the counter. What we don't know, of course, is what doses. There's evidence that lower doses of lithium orotate are anti-inflammatory, pro-cognitive, neuroprotective, if you will. So yeah, I love that idea. That might be an interesting idea as well. And of course, the cascade you talked about, part of it is now I don't have lithium around to inhibit GSK3 beta, glycogen synthase kinase, which is a kinase that is phosphorylating and activating enzymes all over the place and causing all kinds of disruption. I like the school teacher and the student, student analogy. I'm going to use that one.
Well, it's interesting. It sort of raises this fundamental question, what should we all be on is the super pill? And I remember about 10, 15 years ago, there was a tremendous intoxication with being on a statin. Of course, they're anti-inflammatory, but statins are also, they do impair insulin signaling, actually, in many people. That's quite contrary to lithium, which is anti-inflammatory. It can actually benefit insulin signaling. In fact, lithium signaling inside the cell is identical to the insulin signaling cascade.
Yes, interesting. Metformin's another one that had a lot of play. And now, of course, the GLP-1. So I don't know. Should we be recommending a cocktail? These kinds of things. I don't know.
Because the poly pill of exercise is so nauseating for most people.
Exercise does all of the above. Yeah.
Yeah. So exercise is the ultimate poly pill, but that's got too many side effects.
Yeah, that's true. Just to put a cap on the lithium thought, a lot of people think of lithium as anti-cognitive or cognitively impairing because of our prescribing higher doses, let's say.
Yes.
For bipolar. But I think what we're talking about is lower doses may in fact, improve cognition. It's a very different way of thinking about it. Well, as we get ready to wrap up here, Roger, of course, we've got to think about the future. So what are the unanswered questions here? What else? Of course, we need more effective therapies, ideally even something FDA approved or highly evidence-based. But what are the other kinds of questions that we see here?
Yeah, look, I think that for me, there's two or three questions that jump out with respect to long COVID. First is, I think that it's going to turn out that this is going to have many different factors, many different pathophysiologic aspects. So I think it's about, are there groups of patients? Can we separate them into people who are experiencing long COVID with predominantly CNS involvement or prominently non-CNS, and then within the CNS, prominent cognition or prominent reward? So sort of sub-phenotyping. I think to me that's a logical way to begin refining what the underlying substrate is. I think that's the way this is going to go. I think secondly, again, mechanisms should inform therapy. And I think you and I have been talking about different categories of treatments, different examples within the categories. There's a lot of resources now, like B as in billion of dollars now being spent looking at this, not just mechanistically, but therapeutically. And I think, you mentioned chronic fatigue or irritable bowel, these types of syndromes. I think it would be a bit sort of quixotic and a bit of a fantasy to say we're going to have a therapeutic for long COVID overnight. I don't think it's going to quite happen. But I think what we can do is at least find we have treatments approved, for example, for chronic fatigue syndrome, we can debate how strong they are, how good they are. That's a separate debate. But I think that, I don't think it's unreasonable we're going to see this. We're going to see some of these therapeutics being looked at, and some will eventually get an FDA indication. That's how I do see it. And I don't think it's going to be just necessarily pharmacologic. I do think some of these other modalities that we talked about could also, in fact, get over the wall, so to speak, with adequate and well-controlled study evidence.
Yeah, I go back to the sequestration theory and the idea of antivirals. I mean, there might be certain patients who especially have that, and maybe we can find them shedding virus or something. And that sort of reminds me, you mentioned the pandas, and one of the treatments for pandas is very high-dose penicillin to eradicate, especially if you can catch it relatively early. But, perhaps that kind of refinement of, like you said, individualizing is always the goal here, personalizing, individualizing our therapies. And, of course, it's been a bit of a Don Quixote kind of exploration for us to truly personalize and individualize treatments in psychiatry. We don't have great biomarkers, but certainly hope springs eternal. And I think when you're dealing with the immune system, we might have a little bit more of a way to do that. Again, I go back to my fascination with psychoneuroimmunology. It's the immune system is also intertwined not only with the metabolic system, but with the neurologic system. And the immune system is throughout our entire body. It interacts with every organ system, as you said. No wonder long COVID can have all these different symptoms. So we do have a lot to learn. COVID is not gone, of course. And so I think we shouldn't just completely put it in the rearview mirror here. But Roger, as always, greatly enjoyed our conversation.
Talking with you, always fun.
Talking with you always fires up my brain and makes me think of all kinds of different things, and sometimes generates lots of questions. But thanks so much for your time, Roger.
Great to be part of this, Andy. Always fun. Take good care, everybody. Thanks for joining us.
Yeah, hope to see you soon. And of course, for more of our podcast, you can get our podcast, by the way, anywhere you get podcasts. It's NEI Psychopharm, or you can search me, Cutler. I'm indexed as the host. And for other educational offerings and products and services that we provide at NEI, please go to our website, which is www.neiglobal.com. Thanks for listening.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.